Bismillahirrahmanirrahim. Today we are going to talk about another important monitor for the acid base is the buffer base, and this will be followed by strong ion gap. Buffer base. Before we talk about buffer base, we have to know that we have the total weak acids. Total weak acid, which is formed of albumin, globulins, and inorganic phosphates. The albumin, if it is present in gram, it should be converted into mole equivalent, but due to the presence of albumin, in this case, we convert albumin into charges according to the charges of albumin because it is affected by the pH. It has a formula, so the albumin should be multiplied by 0.25. So this is albumin is 4 gram per percent or 40 gram per liter, and if you multiply it by 0.25, it will give you about 10 ml equivalent or around 11 ml equivalent. When it comes to the globulins, also it has a formula, so it should be multiplied by 0.09, and it will give you about 3 or 2.8 or 2.7 ml equivalent. And the inorganic phosphate is multiplied by 1.8, that is 1.8. So all of it, the total weak acids, the charges on the total weak acids will equal about 16 ml equivalent. When you look at the buffer base, I've mentioned before that the strong ion to start with, the positive charges equals the negative charges. This is electron neutrality. This is the cation, sodium, potassium, calcium, magnesium. These are the positive charges. Equals the negative charge, which is chloride, bicarbonate, and the total weak acids. The strong ion difference is the difference between sodium and chloride, and this difference we've mentioned before equals 40, which this 40 is the buffer base. So the buffer base or effective strong ion differences equals bicarbonate and the total weak acids. This is 40 ml equivalent. This buffer base, usually the increase or decrease in buffer base, sometimes when we look at this is an important point. We have mentioned before that there is some sort of electron neutrality between this total weak acid and bicarbonate. Increase in the phosphate by the inorganic phosphate will be associated with decrease in the bicarbonate, but the total together will be 40. Or decrease in the albumin will be associated with increase in the bicarbonate. Decrease in albumin 1 gram will be associated with increase in the bicarbonate 2.5 ml equivalent. So this decrease here is compensated by increase here, so the total even is 40. So in hypoalbuminemia, there is increase in bicarbonate, but at the same time the buffer base is the same. In hyperphosphatemia, the decrease in the bicarbonate, but the sum of the buffer base itself, this plus that, is 40. So it changes here. This is a compensatory. So you should take care of this. In the case of hypoalbuminemia, which is common in critical patients, there is concomitant increase in the bicarbonate. The buffer base does not change. So it will be 40. But this will affect some other items. Increase in the bicarbonate will increase will lead to decrease in the anion gap for by the way, because bicarbonate, the anion gap is sodium minus chloride plus bicarbonate. If this is increased, it will be less than 12. So this is should be considered when you discuss the cases. So the buffer base is bicarbonate plus total weak acids. Here this is a normal, as I mentioned before. This is the buffer base, which is bicarbonate plus the total weak acids. It forms about 40. This is a normal bar. If there is some sort of hyperphosphatemia will be associated with what? With the decrease in the bicarbonate. This is the only thing. So this decrease in the bicarbonate, but the two together, this is total, the buffer base will be 40 as it is. But here the decrease in the bicarbonate will have its effect on other things. Decrease in the bicarbonate, this will be associated with increase in the anion gap. Sodium is normal. This is chloride, but this is a decrease, so this is anion gap. So this is an anion gap metabolic acidosis. So this is an important part. But at the same time, when you look at the strong ion differences, no change in sodium and chloride. The strong ion difference is the same. So no change in the strong ion differences because it is the same, no change. And at the same time, the buffer base is the same. But what appeared here is the anion gaps is high anion gap. High anion gap due to the decrease in the bicarbonate. So this is an acidosis with high anion gap. This is an important point. Acidosis with high anion gap, normal buffer base, and normal strong ion differences. So this is when you look at the pathology from different angles, I think this is good to make good interpretations. When you have an albumin, decrease in the albumin I've mentioned with a zero albumin, which is not compatible with live, but hypoalbuminemia will be associated with increase in the bicarbonate. So the concomitant increase in the bicarbonate, but the buffer base, no change in the buffer base. No change in the buffer base, no change in sodium, no change in chloride, so the strong ion difference is the same. No change in the strong ion difference, no change in the buffer base. But to look at the anion gap, so there's increase in the bicarbonate with the chloride, normal chloride, normal sodium, so the anion gap decrease. So this is metabolic alkalosis with low anion gap. Metabolic alkalosis with no anion gap. So we caught, we catch this pathology from one angle. This is strong ion difference is the same, first is the same, but this is the pH in this case, it is alkalotic with anion gap, low anion gap. So this is, as we have mentioned before, hypoalbuminemia will be associated with increase in the bicarbonate, concomitant increase in bicarbonate. So hypoalbuminemia will be associated with metabolic alkalosis. This is a buffer base from another interpretation. Buffer base, decrease in the buffer base will be associated with decrease in the bicarbonate. These are the causes of decrease in the bicarbonate we have mentioned before, or increase in the buffer base due to increase in the bicarbonate. These are the causes for increase in the bicarbonate. We can study this is the relation between the base excess, buffer base, strong ion differences, a normal anion gap. When you come to the normal anion gap, it changes I have mentioned before. This is usually change in the anion gap through problem of pathology, either in the gastrointestinal tract or the kidney. In the case, say, look at this. If the patient is having some sort of diarrhea, diarrhea means he's losing bicarbonate, and this loss of bicarbonate will be associated with concomitant increase in the chloride. So the patients will have hyperchloremia. This is hyperchloremic metabolic acidosis. Hyperchloremia increase in the chloride, so the difference between the sodium, which is normal, with the increased chloride will be less than 40. This is a metabolic acidosis. So from the strong ion difference, this is metabolic acidosis. When we come to the buffer base, the buffer base here, there is loss of bicarbonate, so the buffer base decreased, so there is a decrease less than 40. It is also metabolic acidosis due to decrease in the bicarbonate. When you come to the anion gap, this is a normal anion gap because we said normal anion gap because sodium minus chloride and bicarbonate. Decrease in the bicarbonate was associated with concomitant increase in the chloride, and the two together 130, so there's no change, so the difference is 12. So this is a normal anion gap. When you come to the strong ion differences and strong ion gap, there is no change here. There is no increase in keto acid, lactic acids. It is not a problem of added acids, whether fixed or non-fixed acids. So the strong ion differences, strong ion gap will be the same, will be zero. When you come to the base excess, here in this case, there is the base excess. The bicarbonate itself has been decreased less than normal because here there is loss of bicarbonate. So when you come to the base excess, this is metabolic acidosis with decrease in the bicarbonate. So there is base excess is negative base excess. Base excess here it is base deficit. So this is the relation between when you study this bar with the pathology. I think it's easy if you remember all this. When you come to the high anion gap and see the relation between all these high anion gap, this means that we have added acids. This is either in the form of keto acid, lactic acid, or fixed acid in the case of renal failure. This acid will increase, react with bicarbonate, and its increase will be on the expense of bicarbonate. So there is a decrease in the bicarbonate. So in this high anion gap, we mentioned this is a decrease in the bicarbonate. So in the buffer base will decrease for sure, will be less than 40. Strong ion differences change. Sodium and chloride the same. So it is 40. This is one angle, another angle. When you look to an ion, strong ion gap, for sure it is increased because now we can measure this keto acid, lactic acid, or fixed acids, and this is the difference between this and that. Will give us it is more than zero. It has a value. It has a number. When you come to the anion gap, this is sodium minus chloride plus bicarbonate. Bicarbonate decreased. So the difference is more than 12. This is high anion gap. What about the base excess or base deficit? Also, this is a decrease in the bicarbonate, so this is a base deficit. Also, from this chart, I think it is easy to study it. Thank you for this strong ion, the buffer base. Come to the second part for the monitoring, which is the strong ion gap. I think we have mentioned before. This is a strong ion gap. This is normally, usually, it has a low value. That's what is negligible. We have mentioned before. This is due to the presence of the keto acid, lactic acid, or the fixed acid, which usually they are not retained in the normal physiology, so they have no value. But sometimes they have a value if there is some sort of ketoacidosis, as in diabetic ketoacidosis or lactic acidosis due to hypoperfusion, hypotension, or hypoxia, something like that, or fixed acids like in the case of renal failure. So this will increase on what? Increase on the expense of what? Of bicarbonate. It will react on bicarbonate, so the bicarbonate will decrease. And in this case, strong ion gap will increase. There is decrease in the bicarbonate, so the buffer base will decrease, and this is this metabolic acidosis. At the same time, strong ion difference is no change, so it's normal. When you look at the anion gap, there is increase in the anion gap because there's decrease in the bicarbonate because the bicarbonate has been consumed by this acid, the fixed or non-fixed acid, so this increase. When you come to the look at the basic excess I mentioned before, this basic excess there will be deficit due to decrease in the bicarbonate, and this is strong ion gap increase. This is strong ion gap and the normal anion gap. Normal anion gap, this is if there is a patient with normal anion gap, for sure strong ion gap is zero because normal anion gap, in normal anion gap, which we have mentioned before, there is a loss of chloride or bicarbonate through the gastrointestinal tract or to the kidney, and this loss of one of them will be compensated by increasing the other. And the normal anion gap, there is no acids added, whether keto acid, lactic acids, or fixed or non-fixed acids. There is no increase in these fixed acids. There is only loss of either chloride compensated by increasing bicarbonate, or loss bicarbonate compensated by increasing the chloride. So this is in this case, the strong ion differences or the strong ion gap will be normal. It will be zero. So, but this is an important point. And thank you.